All right, fantastic. Well, I just wanted to thank you guys for the invitation. It's always a pleasure to speak to you, and thank you for accommodating a satellite type of situation. Usually, in years past, I just give a little brief intro to what I do, and I graduated about 4 years ago and have been working at Cooper. Mainly, my time is spent as a consultant, and then I do see some outpatients. And the majority of what I see is trauma-based. Cooper is a level 1 trauma, so that's the type of patients we see. What I'm going to go through is the information that you want to abstract from a consult and how to provide your colleagues with the most useful information. And I think we all know that the first thing everyone looks to when we see a consult is what the impression is. But there's a lot of thought that goes into creating a good consult. Are you guys on electronic medical records yet?
Yes and no. Mostly
Okay.
no.
What's the situation at Temple?
There's a computer program from the 1980s that we use for orders. And
Okay,
then
so you're still just doing that like MDOS system. All right, so I think, we always want to know, why are you being consulted? And 99% for rehab, it's for a disposition. But there's so much more that we can offer, and we should be aware of what we can offer. What are the tools that are in our toolkit? And a lot of people don't actually know what PM&R is, so it's our responsibility to educate our colleagues and showcase what we can do. And Dr. Cruz is a fantastic example of what we can do. He's, he wears many hats, and as when you get the opportunity to work with him, you feel very blessed for his knowledge bank. But what our goal should be is to realize what the primary team is asking, and also try and figure out what else you can offer. Even if it's not blatantly asked, try to find a situation that you can solve. So I'll just go through some types of patients. These are the patients that I typically see in the trauma center. Concussion versus a traumatic brain and a spinal cord. Amputee. Burns are more seen at Temple. We have very few here. We have a lot of gunshot wounds here in Camden, and stab wounds. Ortho, any type of simple joint replacements versus multi-fractures. Neuro is stroke-based. I know you guys have a wonderful stroke unit, so that is where you do a lot of your consults as well. Cancer patients, there's the lung floor, so I know that you guys see a lot of cardio and pulm deconditioned patients, and there's a lot of wound care from unfortunate, the immobility and the sequelae of immobility. So usually when I start my eval, I would like to know what hand dominant this person is, because if it's a stroke patient and that's their dominant side, we're going to have to work quite hard to get them as functional as possible. And then when were they admitted, and give the reason for why they were admitted. And for myself, I like to know if it's a car accident, was this person a driver versus a passenger? Were they seatbelted? If it's a motorcycle accident, was there a helmet? At the scene, was there loss of consciousness or amnesia? Was there alcohol on board? How was their behavior initially? Because we usually aren't privy to that. We don't see them that instantly in the field. But by the time they get through the ER and get settled into their room, quite a lot of time has elapsed. So you want to know what their initial behavior was, if they were responsive, if they were combative, and what their admission GCS is. Not necessarily the GCS that you see them at the day of consult, but what was the original? And did they require to be intubated and sedated? Because you want to know the time frame of when any procedure occurs. That's very important for our timeline. So let's then go to, we want to know, what did they sustain? And is this, is my speed okay with respect to the turning of the slide?
Yeah, it's coming through pretty clear today.
Perfect. All right, so you want to know what the injury is. Did they have to go to OR immediately for an emergent, decompression or subdural evacuation? And what was that procedure? Who was the surgeon, and the exact date? Especially for items that may need to be removed, like the trach, the PAIC, or the IV filter. I remember doing admissions, like at 9 p.m. at night when I was a PGY2, paging through like a 70-page transfer and trying to figure out when was the peg placed. And so I like to condense this so that for people who are doing the admission at a rehab place, everything is nicely laid out. The timeline is very visible so that if you have to contact the surgeon, you know exactly who it is. And if you need to know the date of placement so that when you want to take out the IBC filter, you know that it's an appropriate time. So this is more for kindness to the people who have to do admissions on the transfer. You also want to know, was there any complication, requiring that person to go back to the OR? And also, why are we consulted? Like I said, normally it's for disposition. It may be for pain control or bracing, but I like to just put that in my note for why they were requesting our service. So this is what my first few lines on my H&P might look like. You guys can read this yourself. I'm not going to read it to you. So I just like to see everything in one snapshot, and I like to know, what am I going to do for this person? So we always like to start out with pain. Pain is the hardest, most subjective item. A lot of people try to ignore asking this question because it is time consuming and you usually get a nebulous answer. But it's very important to understand because pain usually, unfortunately, delays a patient's progress. So you want to know, where is the site of pain and what are they rating it as? And I like to educate the patient before I ask for the number, because the patient will normally say it's a 10 out of 10. I always try to educate them of what a 0 means, what a 5 means, and what a 10 means. So if I'm seeing a female, I say a 10 out of 10 is you're giving birth to a child without an epidural. If it's a male, my comparison is I'm ripping your arm out without giving you any type of pain medication or sedation. So once they have that severity understood, and then I say a 5 is tolerable, you can function, and it's not the only thing on your mind. So then sometimes they reorient themselves and give you a better estimate of their pain. And be aware of the patient who says they're 10 out of 10 and they're calmly speaking to you and their pulse is 50. Someone cannot be a 10 out of 10 that's not writhing in pain, that's not gasping for air, and has a pulse that's less than 100. So keep that in mind when you're assessing pain. And you always want to ask, what makes the pain worse? The example for breathing, coughing, and sneezing is a rib fracture pain. That usually instigates worsening of their pain. So just try and figure out whatever the body part is injured, you should be able to deduce what activity will cause more pain. Rest is usually always going to make something better. And if they are getting medications, I like to know, how much pain reduction are we talking? Does it only drop 1 point on the scale, or does it drop 50%? Because then you know that you're doing something that's adding value and you're giving them a benefit for whatever recommendation you're giving. And try to get a description of the pain. This helps you go down the path of if it's a neuropathic type of pain. So you want to know, is there any type of numbness, tingling, burning, radiation? Some of the pain is mistreated. Patients will continuously complain, and then we start throwing more and more narcotics, but we're not treating the pain generator. So it's very important to understand, if it's a neuropathic source, that allows us to use Neurontin or Lyrica and something that's other than a narcotic, which is what we always try to hope for. We don't want to increase someone's narcotics. That's going to make more sedation, more constipation, and might delay their mobility. So I was talking to Justin, and I'm not sure how much concussion experience you've had, and I think it's a very hot topic. A lot of people are interested in concussions. So when you see your patient, and I'm just going to give an example of a concussion patient, the related or expanded review of systems for that diagnosis or entity. you can go through the head to toe review of systems, but we really want to hone in on what is the diagnosis that we're trying to treat, so we can symptomatically also treat for that review of system. So for a concussion patient, I usually like to ask these following questions: if they feel lightheaded on transitional movement, or if they feel lightheaded while just staying stationary. Are they sensitive to noise? Are they having daily headaches? Are they, in the temples? Are they in the occipital region? Where exactly are they located? And the reason I highlighted nausea is because this one can be slightly tricky. You can have nausea from pain. You can have nausea because of vestibular symptoms. You can have nausea because of Percocet or any type of narcotic, or sometimes, and the medication one is very important. You want to ask the timing of the nausea. Does it come 30 minutes within receiving a medication? So then it can help you hone in on, do we need to change the medication, or do we need to add something specifically for nausea? So this one is one that I really like to tease out. What is the cause of the nausea? Are they having any vision trouble? Are they having ringing in the ears? Mood is more for family. You can ask family members if they've noticed a change in their mood or behavior, if they're sensitive to light. Are they dizzy upon standing? And how is their sleep? Normally, a lot of patients in the hospital don't get good sleep, so this actually worsens their symptoms for a concussion. Rest is actually the best medicine for this situation. So it's important to understand their sleep patterns, because headaches will get worse, their mood and behavior will get worse. So if there's anything you can treat, focus on those symptoms. I like to go through a functional history. I'm very curious about their occupation, because I want to know how hard we have to work to get them back to where they need to be. And also, if they're a lawyer, you're going to be very careful about everything that you do and say. If they're a physician, you know that you can talk with your medical jargon. If it's someone that, appears that they don't have a very high education, you're going to be breaking it down very simply for them. So it's very important to know the level of education for your patient so that you can appropriately treat them. I also like to ask who they live with, meaning, are they the primary caretaker? Do they have young children that they have to look after? Is their wife completely dependent on them, so that when the person gets back into their home setting, are they going to have the help that they require, or are they going to be the person that is still relied upon? You want to know, for patients that have any type of lower extremity fractures, how many stories are in their house, because you want to know how many stairs they're going to climb, or if they could create a first floor setup to avoid the stairs. And if the family members can't help, are there any friends or other relatives that are available for the time of discharge, so that the person can hopefully transition back home? And you want to know what they were like before this happened, specifically with their ADLs. Were they able to bathe, toilet, dress? Could they do their own chores, their own cooking, bookkeeping for finances? And you want to know if they were ambulatory, with or without a device. These all help you to know what we want to help them get back to. And also, if you see a patient in the ICU and the family members are there, and you're trying to allow them to understand your role, in the ICU, it's a little aggressive. These patients are probably sedated, and, mobility is not the first thing on everyone's mind, but you can let the family know that we just like to be involved early, so we can help them get back and restore function as soon as feasible. So we like to know how they were functioning prior. So we can ask next, the social history. The driving is important. If it is a concussion patient, their reaction time might be slow, so they might not be cleared back to drive. If it's a patient that has seizures, that's a huge issue, and usually we revoke their license if they have new onset seizures, for everyone's safety. You want to know about smoking behavior. My favorite is when you ask, do they smoke, and they say, occasionally. and then you ask, or they say the statement, oh, only when I drink, and then you ask, how many times do you drink? And they say 3 times a day. So, you know, you want to make sure that you understand their social behaviors. And marijuana use, IV drug abuse, these things in my practice, we actually have a pain practice. So if they have any illicit drug use, we don't accept them into our practice. So this is one reason I ask it. It's not necessary, but sometimes if you're going into the world of pain management, it's important to know other behaviors. If they did heroin, for example, morphine is not going to work in them because that is too close to the composition of opium. So you want to make sure you know their behaviors. You always want to review any imaging. You should not believe everything you read, and you should always look at the images yourself. There's so many times that you're going to find something that a radiologist might have missed. So it's important that you review it for yourself, and just to have an understanding of what normal looks like, so that when you see abnormalities, you know how to respond. These are the few labs that I particularly pay attention to. I want to know, was alcohol on board? Was there any other illicit drugs? Was there a drop in their hemoglobin? Because that's going to influence, once they get out of bed, they might be orthostatic. I have a personal interest in osteoporosis, so I always like to know their calcium levels. And if it's a spinal cord injury patient that's going to be fully immobile, even if they have a low calcium, you don't want to necessarily supplement, because as they're immobile, they're going to have hypercalcemia. You know, so these are some important things to know. If they're a rhabdo patient, you want to follow their CPK levels, because you're not going to do any aggressive range of motion or mobility. If their CPK is severely elevated, you'll cause more damage than good with even gentle range of motion. So you always want to include past medical, surgical, and especially family history. There's a lot of wealth in the family history. Medications has multiple exclamation points, because a lot of patients have no idea why they're on certain medications or what medications they're on. You'll ask them and they'll say, I'm on the purple pill or the small blue round pill, but they really have no clue why they're on what they're on. So I like to make sure you validate it from the patient, or you validate it at the pharmacy. In New Jersey, we have the New Jersey prescription monitoring program. I'm not sure if this is going to come to Pennsylvania, but it's a system where you can log on and you can see where and who dispensed a specific medication, so you can track behavior as well. So it's very important. The MedRec is one of the most important, valuable tools that we can make sure that we review it ourselves. Allergies are important, because a lot of meds get put under the allergy section, even if it's just a sensitivity. So it's very important to know, do they get a full blown out angioedema, you know, throat closing off situation, or is this something that their stomach just hurts and they don't like, you know, how it feels? So make sure you understand, because there's a lot of pain patients that are going to say, I'm allergic to Percocet and morphine and fentanyl. They're going to give you the list of 90 meds that they're allergic to, and the only one that works is Dilaudid. That seems to be the running theme. So make sure you understand, what is the actual problem, or are these just drug-seeking patients? Physical exam, I feel that you're very well equipped with that. That's our specialty, so I'm not necessarily going to go through an entire exam, but we'll just highlight what we do for a concussion. So besides for your normal motor, sensory, reflexes, what are the questions you want to ask on a concussion patient? Majority of people will ask date, time, place, and precedence. So at some point, the patient will start to memorize the answer, or, you know, it's written in front of them on the board, so they'll be able to cheat. So I like to ask other questions besides for those 4. And, you know, you can always ask family for the background. You know, has there been a change in their mental status? But if no one's around and you want to get the information yourself, you can start asking these questions. And this is just a few that I use. Please feel free to create your own cog screen. I like to start, if they look like someone that should know the calendar months forwards, I just ask them to go through them backwards. If you know, there's no language barrier, if I don't see any problems, I'll ask them to recite the alphabet, skipping every other letter. I have them do serial calculations. I have them spell the word world backwards. Recall with 3 objects. Now, I usually actually forget to say, remember these 3 words, and then, you know, at 5 minutes, I actually always forget. So while I'm in their room, I have them close their eyes, and I usually ask them, can you tell me 3 objects that were on your tray? So that's how I do short-term recall. But if you remember to ask them those 3 words, and make sure you ask them at the 5-minute mark what those 3 words are. But this is my fail-safe method if I forget. And I also like to know what their knowledge bank is for current events. The next is balance testing. If this is someone who is coming to your outpatient clinic and they're walkie-talkie, you can check balance. If it's someone who's in bed, I would say ask a therapist to be with you when you're doing balance testing. So there's a score, it's called the BESS system, balance error scoring system. This is where you ask the patient to do the tandem gait. That you ask them to walk in a straight line, toe, heel, just like they do, the drunk driving test. You see if they are looking down, how unsteady they look. You ask them to actually raise their head and not watch their feet, so you can see how unstable someone is. The next test, you will ask them to stand hip width apart, and keeping their eyes open, you can see if there's any sway, and then you ask them to do eyes closed, keeping their hands on their hips, and you can see within 10-15 seconds, what are they doing? Are they opening their eyes? Are they reaching back to hold on to something? Are they putting their foot out to balance like a kickstand? And then next, a higher level testing would be single limb stance. You want to do the same thing. You do eyes open, either limb, you see how they do, and then you take away their visual system, asking them to close their eyes, and you see how they do on that. So these will be good in testing their equilibrium and balance. And there's a lot of things that don't get discovered until you challenge their balance system. So next, a quick summary. You just want to write down what your impression is, why you're treating them, and usually, it's a nice little statement for why we were consulted again, and seeing if we discovered something on our physical exam. If someone has a new neuropathic syndrome that wasn't originally discovered, you can add value by doing a very thorough physical exam. Now, our baseline goal should always be to improve someone's function and improve their quality of life. How can we do that? We'll start off with some simple recommendations, and then I have created some templates that help guide my recommendations for certain categories of patients. So if the patient seems stable, then, make that recommendation that we can begin PT and OT. I'm not sure how the system is at Temple, but nursing plays a crucial role in also helping with transfers and doing some gentle passive range of motion. If you have unstable vitals, if the hemoglobin is less than 7, if there's an open abdomen, definitely hold the therapy and make sure you relay this to the primary team as well as the therapists. This is important to hold it if the patient is not stable. Know what precautions the patient should be on and educate your patient for what those precautions are. If they are hip precautions, ask the patient, do you know what you are allowed to do, what you're not allowed to do? And then educate them on, do not bend your hip more than 90 degrees. Do not cross your legs past midline. Do not pigeon toe in. If it's a bypass patient and they have sternal precautions, allow them, always ask, what do you know you are allowed to do, what you are not allowed to do, and then you can proceed from there and make sure the patient is well educated on their restrictions. The Borg scale is perceived rate of exertion. These are more valuable tools for cardiac and pulmonary patients, where you allow the patient to dictate how they can advance and progress based on symptom of difficulty breathing. If you cannot hold a conversation, this is when, you know, someone is doing more intensity than they should be, and you allow them a rest break at that point. If it's a cancer patient, there's a lot of METs that go unseen sometimes. So you always want to check if these, before I get a patient out of bed, if that is a newly diagnosed cancer patient, I always like to make sure we get a full body scan, checking for METs to weight-bearing joints before I allow the patient to get out of bed. You can always allow bed range of motion and simple stamina endurance conditioning exercises while they're in bed. So it's not that you have to delay therapy. It's just that you want to wait to get them out of bed if there is anything that has spread to the femur. If these patients are immobile, they're on the vent, they're sedated, what can be done? There's still value that you can add, and you can prevent the consequences of immobility and deconditioning. So, like I said, nursing is heavily involved, and you would like to educate any nursing or techs, any extra ancillary staff that is available. You can educate them on how to do range of motion. I always educate the family members to also get involved, because every single range of motion that a patient gets will help them prevent contractures. So you want to make sure that you show them proper body positioning, how to hold the lower extremity when they're ranging, and make sure that the family is aware that if there's a fracture, they are not to do, you know, range of motion on that side. If the person is monitored, then you can let them know. If the patient starts having an increase in blood pressure or tachycardia, you know, back off. So it's important, you know, even gentle range of motion can cause problems. So you want to make sure that the patient is stable enough to get this done, and that you properly educate the family members. If a person's not spontaneously moving, it's a good idea to get them with prophos and make sure you have the kickstand so that they don't externally rotate and have superficial perineal nerve compression. Otherwise, that will lead to a foot drop unnecessarily. So if there's anything you can do to prevent a problem from happening, that's where we want to be adding our recommendations. If it's a spinal cord injury patient, or if it's someone that has bilateral lower extremity fractures and cannot get out of bed, you can add the trapeze so that at least they can do weight shifts, they can do some upper body conditioning, they can still have some freedom of mobility. If you see that they are starting to have edema because of immobility, you want to check the marker for nutrition. You can get a prealbumin if they need protein supplementation, or just, you know, TED stockings. This is a good opportunity to add a simple intervention. And I like to have patients shift their position into a chair. If a patient cannot get out of the bed, a lot of beds do convert into the chair position, so this is another opportunity for movement. If it's a fall patient, usually it's, you know, it's quite protocol these days that someone will get a cardiac workup, you know, they'll get a neuro workup. And it's important to look for medications. So this is where we can also help. We can review all the pain medications, anything that's causing
I think we lost you.
A lot of them can be on Plavix, aspirin, Coumadin. So if this is a high-risk fall patient, they might not want to continue the Coumadin. So it's very important to, you know, comb through all these medications, see if anything can be eliminated because of the risks of polypharmacy, and also to check what meds, if they are going to be a high-risk fall patient, that can be eliminated. So Coumadin is one of those culprits. It's important to check orthostatics, B12, and then again, educating your patient if there are simple modifications in the home that can be done to prevent falls. If this is someone that looks frail and elderly, you want to start doing the workup for osteoporosis, how we can prevent, if they need any treatment, any nutritional supplementation, so that hopefully these people don't end up back with fractures. So if it's a pain patient, let's find the source of the pain. And neuropathic pain is something that gets missed many, many times. It's a fresh amputee and they have neuropathic pain, but you know, the person might be asking different questions and not targeting the neuropathic component. So there's not true treatment of the pain source. So it's really crucial to ask the appropriate questions. Some easy fixes, you know, if it's a MSK pain, try ice or heat directly, and you want to make sure that the ice is not directly on the skin because that can cause a burn. Elevate to decrease any edema and swelling. If it is not a fracture, you can try anti-inflammatories. Again, there's a lot of caveats with anti-inflammatories. If the patient has kidney problems, if they have hypertension, if they have any GI ulcer, unfortunately NSAIDs are limited, but it is a great medication that sometimes gets underutilized. Some of the neuropathic agents, I was mentioning Neurontin, Lyrica. You can try Cymbalta, amitriptyline. There's many, many agents that can help with phantom limb pain, any type of neuropathic syndrome, if they're having radiculitis from a slipped disc. You know, these are nice options that you have in your toolkit. You can try some muscle relaxers. Whenever someone falls, there's a reflex muscle contraction that also can be another pain generator. So that's where muscle relaxers can come into play. And you can always use lidoderm patches or Flector patches, something that's topical, so that if it is someone who is very sensitive to medications, you know, you always want to go for the least sedating option. If it is someone that is a chronic narcotic user, you can increase their short acting by 25%, and that's usually a good baseline. I like to keep the long acting the same, but you can make that recommendation post-op that they can increase the short acting by approximately 25% without causing any sedation. If they've been only on a short acting, but they've had pain for more than 3 months, that's when you can make the recommendation they may benefit from a long acting option. Some people respond very well to topical pain and compound creams. We have a pharmacy that compounds a neuropathic agent, a muscle relaxer, anti-inflammatory. So these are really wonderful options for someone that does not want to take medications. And acupuncture is also something that can be recommended. I'm not sure if anybody offers it at Temple per se, but you know, a lot of people like to be holistic these days, so acupuncture can be another option. If it's your amputation patient, for transtibial, you want to make sure that you're not causing any knee flexion contracture, because that's going to impact their ability to have a prosthesis fit and impair their ability to ambulate. So make sure anytime you check in on your transtibial patient, if they're not in a knee immobilizers, make sure they're not keeping pillows under their knees. If it's a transfemoral patient, you want to prevent a hip flexion contracture. And majority of patients, you know, in the initial phase will spend their day sitting. So you have to encourage 3 times a day for them to lie prone to stretch out the hip flexion. The hip flexors, sorry. You want to make sure that they stretch and prevent the contracture. For those that you know, are new amputees, they're going to have to make sure the focus is on upper body strengthening. For any transfers, for crutch use, a lot of the powerhouse is now going to be in their upper extremities. So you can give them bedside exercises that they can just do against their own resistance, and encourage that 3 or 4 times a day. You want to empower your patients to do the exercises and not just rely on physical therapy. I see that problem all too often, that the patient will just wait for therapy, and you know, there's a lot of time that gets lost in between. So I like to give patients printouts of exercises, you know, based on their cardiac status too. You want to gauge what your patient can do, so that their time is well utilized while they're in their room. And then again, I educate family members to help be their coaches to make sure that the exercises get done 3 to 4 times a day. And family is a wonderful resource. If they're well educated and well motivated, they'll participate and be part of the team approach for your patient's care. Lastly, you want to educate your patient on phantom limb pain and the sensation so that the pain options are appropriate, the medications that are targeting the right problem. For concussions, education, again, is your best tool and asset that you want to make sure the family understands what to look for so that if the patient is unaware of their cognitive change, the family is aware so they can bring them back in. Rest in the first week is very important. I encourage patients to avoid television, cell phones, computers, anything that has audio and visual stimulation because it can be overwhelming for the healing process. You do want to give as much rest as possible. I know that is quite boring for the patient, but it's very important for the healing process. If you restart someone too quickly, back to their normal life, their healing and recovery is actually delayed. So it benefits the patient to heal properly in the beginning and allow themselves to return once they're fully healed. If it's someone very high functioning, students, high level professionals, I always get a neuropsych consult because I want to make sure that there's nothing missed on their cog eval. There's so many elements to the thought process, judgment, insight, short-term, long-term memory that can be affected by a concussion. So I like to do a very thorough neuropsych eval so that the speech therapy treatment can be targeted for whatever the deficit is found. For concussions, you can always add magnesium, B2, and fish oil, I will say with a caveat. If it is a bleed, do not give fish oil because that can worsen the bleed. But if it's a simple concussion, then you can give fish oil that will be beneficial for healing. I like to tell patients that a concussion is just like the flu, that everyone has their own time course for healing, but we can treat the symptoms. And this is just my drug of choice. I like Zofran for nausea, and I like meclizine for the dizziness, vertigo complaints. But if you have better experience with another medication, by all means, use whatever you feel comfortable with. For your TBI patients, you want to avoid Benadryl, Pepcid, and Halidol. These 3 medications are always what people are on. Haldol works the fastest, for behavior changes, so that's the first one used. But we want to make sure we avoid things that will have a reciprocal effect and cause worsening of their behavior. You want to educate the team and the family for symptoms of sympathetic storming. You should always follow their sodium levels. And understand agitation versus pain. You want to identify, is there noxious stim? Is this person constipated, and is that causing the agitation? So always do deductive reasoning to find a source for the agitation before you sedate the patient. If they are not sleeping well, you want to regulate their sleep cycle because behavior will be influenced with poor sleep. If you have reestablished their sleep-wake cycle, you'll notice an improvement in their behavior. And for arousal, amantadine is still the drug of choice. If it's a spinal cord injury patient, for blood pressure management, we have a few options. We have the abdominal binder. We have the thigh high compression stockings. You can remind the primary team, especially when nursing is doing turning, or if there's any suctioning, this can cause bradycardia. So you want to have the atropine at bedside. You want to educate the family and the patient about autonomic dysreflexia. A lot of patients, when they're discharged home, they have an ingrown toenail and it sets them off and they come to the ER and, everyone symptomatically treats because that's how we're taught. So it's very important if a patient and family is well educated on the symptoms, when they get to the ER, they can help guide the treatment so that the the patient suffers less when there's random theories being tested. If we know the reason for the symptoms, it's much better efficiency in their treatment. For neurogenic bowel, you want to do Dr. Schwartz's 3-2-1 system. And for bladder management in the acute phase, you do the Foley. Once you're out of spinal shock, you want to reduce the risk of infection. You want to start retraining the bladder. If the patient has the dexterity, to do self-cathing and Q4 urinating, or if you're going to do your Q4 trial, this is, you want to keep an eye on how long that Foley has been in, because some of these things get ignored for convenience sake. So it's very important to pay attention to any source of infection, and you want to retrain a muscle as soon as possible. Just some generic things that you can also throw in. If a patient is smoking, you want to try to be the voice of reason to help them to quit. Smoking does increase pain, and it delays healing for bones. So, this is a nice, maybe eye-opening situation for a lot of patients, that this may be the time to quit. And I like to ask, when you're asking someone to quit a habit, I think it's important to ask them to do something that's achievable. So a lot of people think you have to go cold turkey, and that's just a setup for failure. So I just ask my patients to reduce by 1 cigarette per week, so they don't really feel the difference. So my newer theory is ask people to do things that they can participate in and are more realistic in achieving. So 1 cigarette per week seems to be minimal enough that a patient doesn't even realize that they're reducing it. And this helps them over time. Alcohol abuse, you have to be very aware of. If alcohol was on board, if this is a daily drinker, you want to prevent DTs. So you want to make sure they're on their nutritional supplements, folic acid, thiamine, and if they need to be on Cerax, you can make sure that that wasn't missed. Always, always, always add bowel regimen while on narcotics. Unless they have an ileostomy, you should just make sure that they are on a bowel regimen. And at Cooper, we have behavioral medicine. I'm not sure if you guys have that service, but it's a wonderful service that helps patients with coping and support. If there's a life-changing diagnosis, a stroke or spinal cord or TBI, both family and patient are going to have to understand how to live a new life, and this can be quite devastating. And this is a wonderful resource to help patients learn how to live with their new diagnosis. Make sure a patient's on DVT prophylaxis. If it's a TBI because of a bleed, you're going to want to make sure they have SCDs. If it's a patient that has renal failure or is on dialysis, you want to make sure they're on heparin instead of Lovenox. If they have any acute stress type of diagnosis, then you want to make sure they're on GI prophylaxis, or if they're on steroids or NSAIDs, make sure that they're on their PPI. And anybody that's immobile, that's not getting enough diaphragm mobilization, you want to make sure that they're doing their incentive spirometry. Make sure you educate them on how to do it and how many times that they should do it. I recommend 10 times per hour. That is not realistic. However, if they even did it just 3 times a day, that's fine. In this situation, I encourage more because I know that they're not going to be able to do it, but I'm hoping for a 3 time per day situation. And that's it, my friends.